We're going to talk about the cardiovascular pathology. What we have is basically two main categories. The first one is right to left shunts, and the other one is left to right shunts. So basically, for the right to left, it means that the blood is shunting from the right side going into the left side. So what it comes is just like an early cyanosis. That's why we call them blue babies. It's often diagnosed prenatally or become evident immediately after birth. So usually requires urgent surgical treatments and or maintenance of a PDA. Sometimes we need to take care of the PDA, either close it or just keep it open in some cases because we need it for survival. So they're summarized as the 5 T's. We're going to go through those one by one. So for the persistent truncus arteriosus, it's basically truncus arteriosus fails to divide into pulmonary trunk and aorta due to failure of aorticopulmonary septum formation. Most patients have an accompanying VSD. So basically, what it is that the truncus arteriosus, it's the stem or the main source before the division of the two major arteries, which are the pulmonary artery and the aorta. They're supposed to come from a common place, and that is called the truncus arteriosus, and it's this one. So in this case, it persists and it does not develop or divide into two parts. So, as we can see in this image, the blood does not go from one ventricle to the aorta, from the other ventricle to the pulmonary. So, it doesn't happen that way. It goes from both ventricles to the same outlet, and that is the truncus arteriosus. So what it says here, most patients have an accompanying VSD, as we can see in this image. So this is the ventricular septal defect. So it's basically just an opening between the two ventricles to allow blood transfusion. But what it happens is not like both ways arrow. Actually, it's not. It's just from, as we said, from right to left. So the blood goes from the right side to the left side. So it's this way. So that's the shunt. That's why we call them blue babies. So for the second disease is the detransposition of great arteries, and it says that aorta leaves the right ventricle anterior, and the pulmonary trunk leaves the left ventricle in the posterior side. So the separation of the systemic and pulmonary circulation, that's the outcome. Not compatible with life. If it happens, then the baby cannot live. Unless a shunt is present to allow mixing of a blood, like ventricular septal defect, patent ductus arteriosus, or patent foramen ovale. So it's basically due to failure of the aorticopulmonary septum to spiral. It's just like egg on a string, and this is what we can see here. So if we can imagine this as a string here, and this is kind of look like an egg. So that is what the detransposition of great arteries on X-ray could look like on chest X-ray. So it says that without surgical intervention, most infants die within the first few months of life. So if we just don't do something, then the baby will die. So basically what it is that, as we know, that as it says here, that this is the aorta. The aorta normally should leave from the left ventricle. So this is its actual place, while the pulmonary artery should come actually from the right ventricle. So that's the normal, but that does not happen in this case. So the pulmonary artery goes out from the left ventricle, that is abnormal, and then the aorta as well goes from the left ventricle, and that is also abnormal. So as we can tell, that there is a complete separation between the two circulations, the systemic circulation that starts with the left ventricle, and also it's separated completely from the pulmonary circulation that it just starts from the right ventricle. So that's why it's compatible with life, because the two circulations are separated, so there is no oxygenation happening, and the body goes up to the whole systemic circulation without oxygen, so the tissues cannot use any oxygen and they die. That's why, in order to be able to live, I mean, for the newborn, is to have another opening. For example, VSD, PDA, or patent ductus arteriosus, and that is basically an opening between the two ventricles to allow blood mixing between the two, or like an opening between the two atria to allow the blood mixing between those, or having ductus arteriosus, and that is the connection between the two main arteries, the pulmonary artery and the aorta, in order to allow mixing that blood, so it would oxygenate and go out to the whole body as oxygenated. The reason is, as we said, it's not it's the aorta, it's the failure of the aortical pulmonary septum to spiral, so it cannot basically go into the normal development, and that is it's spiraling. Being spiral. Okay, so without surgical intervention, most infants die within the first few months of life, and it makes sense. For the third disease, and that is the tricuspid atresia. Atresia basically means the absence, just it's complete absence of tricuspid valve, and also hypoplastic right ventricle, and it requires both ASD and atrial septal defects and ventricular septal defects for viability, in order for the infant or the newborn to be alive, to stay alive. So basically, as you can see here, this is the valve between the left atrium and left ventricle, and that should be normal. That should exist normally. There should be an opening allowing blood coming through. But in this case, for the tricuspid atresia, on the right side of the heart, the right atrium and the left ventricle, they cannot communicate at all. As you can see here, there is no opening at all, and that basically means no blood coming from the right atrium to the right ventricle. So this is also not compatible with life, and if for the newborn to be alive, he needs two openings at the same time. The first one is the ASD, and that is allowing blood from the right to the left moving, so it's just this way. And when we say that, that means blood coming from the right atrium, going to the left atrium. There you go, going to the left atrium, and then going into the left ventricle, and from the left ventricle it should go back to the right ventricle. That's how it can have an exit through the pulmonary artery, and then goes to the lungs, where it gets oxygenated, and then come back from the lungs as oxygenated blood into the left atrium, which also would give it to the left ventricle, and then leave through the aorta to go into the systemic circulation. So basically, we need the two openings to be viable. While the fourth disease is the tetralogy of Fallot. It's caused by anterior. So tetralogy is like 4 problems that we have here. So it's caused by anterior superior displacement of the infundibular septum. It's most common cause of early childhood cyanosis. The main issues. So what we have is that there is an anterior superior displacement. It's basically change of a place of the infundibular septum. So that change of a place, it could be, it sounds like simple, but actually it causes so many defects throughout the whole development. So that is the anterior-superior displacement of the infundibular septum. So these, and by the way, this is the most common cause of early childhood cyanosis. So whenever we were asked about what is the most common cause for early childhood cyanosis, the first one to come to mind is tetralogy of Fallot. So basically, number one, it has pulmonary infundibular stenosis, and that is most important determinant for prognosis. This is where it decides. This is the point that determines or decides how what is going to be the outcome for this baby, for this newborn. Pulmonary infundibular stenosis is basically, as it says, it's the pulmonary, it's the base of the pulmonary artery that is called the pulmonary infundibulum, but it is not normal. It is stenosis, as we can see here. So this is all of it, is the wall of it. So it means like stenosed. That means the blood is not having enough space to go out. It's just smaller than the normal. That's for one. That is the pulmonary infundibular stenosis. The second problem is the right ventricular hypertrophy. It looks like a boot shaped on chest X-ray, and this is clearly, we can see it here. This is kind of a boot on the chest X-ray. That is the right ventricular hypertrophy. Well, if we, there you go. This is number 2, and this is the wall of the heart, and we can see what a normal wall could look like here. This is normal, while a hypertrophied wall, that is the right ventricular wall, what would look like. This is the abnormal. So that's for the problem 2. For problem 3, it's overriding aorta. So what basically is meant by overriding aorta is that the aorta, and I'm going to use the blue color here, this is the aorta. It's kind of purple, like it's colored purple. This is the aorta. So it is displaced to be right above the VSD, the ventricular septal defect. So it should start from like the interior of the left ventricle. This is where it normally should go, but actually it's kind of displaced into being open right above the major opening that we have here, that is called ventricular septal defect. And this is it. It's number 4. So number 4 problem form is that we have an opening between the two ventricles, the left ventricle and right ventricle. So that is for the image. There, what it says is that the pulmonary stenosis forces the right to left flow across the VSD, then right ventricular hypertrophy lead, and there's TET spells often caused by crying, fever, and exercise due to exacerbation of right ventricular outflow obstruction. What it's saying here is that because of this pulmonary stenosis that we have here, let me clear it up. Okay, so because the blood in the right ventricle should normally go into the pulmonary artery this way, and it should have the road open. That's normal, but in our case, in this tetralogy of Fallot, there is stenosis of the outlet, so the blood doesn't go comfortably outside the right ventricle into the pulmonary artery. So what happens, it just has to go back into the right ventricle, and that would cause the right ventricle to be hypertrophied because it needs to push that blood out. So if it doesn't go easily through the pulmonary artery, then it will go into the VSD, that is the ventricular septal defect, going into the left ventricle. So basically, this is because of this stenosis that we have here, the blood just cannot go easily this way. So it has to go to the other side of the heart, that is the left ventricle. So, and because of this need to push, the right ventricle goes into being hypertrophied. So what TET spells, so sometimes if baby with a tetralogy of Fallot would be crying or has a fever, or if they exercise, that would cause them to have TET spells, and they're suddenly, that means they suddenly develop deep blue skin, nails and lips. And that's basically after crying or feeding or when agitated. So these TET spells are due to the right ventricular outflow obstruction. So in cases of crying, fever, and exercise, there is exacerbation of the right ventricular function, and that is to push the blood out of it, and that would cause the stenotic pulmonary arch to be more prominent, that stenosis to be more prominent. So this is the issue with this disease, and that's the way to memorize it, prove. So in case of sequading, the sequading basically causes an increase in systemic vascular resistance, which would lead to reduced right to left shunt and improves the cyanosis. So if we want to explain it here, then okay. So sequading basically increases the systemic vascular resistance. The systemic vascular resistance is ultimately what the aorta has to push through. It's basically, when we say the aorta, it's the systemic vascular system is somehow attached to the aorta. And the aorta actually goes out from the left ventricle, as we know. So in case we are increasing the resistance of the systemic vessels, that means it's harder for the left ventricle to push blood into the aorta, because the aorta is getting too much resistance of the systemic vessels. That's because of their sequading, so they're closing, so they're increasing their systemic vascular resistance. So it's harder for the left ventricle to push blood through the aorta. So what that means is the right ventricle by itself is also having a difficulty pushing blood to the left ventricle, because the left ventricle already has its own problems. It's already in a problem because the systemic vascular resistance are already increased, and it's harder for the left ventricle to push into the aorta. So he already has a problem. So the right ventricle also find it really difficult to push into the left ventricle. So what it does, the right ventricle by itself should somehow just push the blood out of it. So if it cannot push it into the left ventricle, it would definitely has to push harder and push into the stenotic pulmonary artery. So this is what sequading do. That's why it improves cyanosis. How it does that? Because the blood, if the blood goes is forced from the right ventricle into the pulmonary artery, that means it's finally going to the lungs. And the lungs are the place where the oxygenation occurs. So when oxygen in the blood, that means less cyanosis, because cyanosis is a sign that the tissues are not getting enough oxygen. So by forcing the blood to go into the right into the pulmonary artery, then it would definitely have to go through the lungs, and it would definitely have to be oxygenated and then come back to its normal position, and that is through the pulmonary veins into the right ventricle, and then back into the left ventricle, and then into the aorta. That means the system of circulation now has more oxygen, so it's less cyanosis, so it improves cyanosis. Basically, this condition, the tetralogy of Fallot, is associated with 22q11 syndromes. An example is Di-George syndrome. So that's for this condition. Let's see what we have here. Yeah, that's the ventricular septal defects, and this is the stenotic. There you go. The opening is already too small. This is the overriding aorta, and it's basically right above the VSD that we have, and there's right ventricular hypertrophy. So now for the total anomalous pulmonary venous return. So the pulmonary veins drain into the right heart circulation, where there is the superior vena cava and the coronary sinus. So this is associated with ASD and sometimes PTA, to allow for right to left shunting to maintain cardiac output. So what we have here is Basically, there is an abnormal positioning of the pulmonary veins. So the pulmonary veins, and these are the pulmonary veins, they should normally, in normal cases, go into the left atrium. They come from the left side, and they come also from the right side. But both sides should normally put their blood into the left atrium. It's the oxygenated blood, and that's from where the blood goes into the mitral valve, into the left ventricle, and then normally goes into the aorta, so that the aorta goes into the systemic circulation, and that the whole body now gets an oxygenated blood. But in our condition, in the total anomalous pulmonary venous return, so basically all of the pulmonary veins are just located abnormally. So they are, unluckily, opened in the right atrium. So they just go, if we can see the image here, they actually move from behind of the heart. It's where this dotted line goes. So they kind of make their own circulation. So they come from the left side still and the right side, but they both are connected somehow without opening in the left atrium, and they just take the blood from the oxygenated blood, of course, oxygenated coming from the lungs, take it in this short circle that has connections, and then go into the superior vena cava or directly into the right atrium. So this is the place where we have the superior vena cava and coronary sinus. These are normal into place, but the one that is coming abnormally, the ones that are coming abnormally are the pulmonary veins. So that is the total. And by the way, this IV, as it says here, it's innominate vein, and this VV vein is called the vertical vein. So that's an FIY. And basically that's it. Yeah, as we said, these are just for your information. That is FYI, actually. Okay, so what else do we have? Nothing. So for Abishton anomaly, so that is the displacement of tricuspid valve leaflets downwards into the right ventricle, artificially atrializing the ventricle. They're associated with tricuspid regurgitation and accessory conduction pathways with right-sided heart failure. So it can be caused by lithium exposure in utero. So basically, it's somehow a simple concept. It's just that displacement. So displacement is this kind of changed from its normal good position into a different position of the tricuspid valve. So it's the valve separating the right atrium from the right ventricle. So this is its a proper place. This is where it should be located. But what happens in this case, it just goes downward. So it's associated, of course, because it's displaced, then it's associated with tricuspid regurgitation. It just regurgitates. And also there could be an accessory conduction pathway and also a right-sided heart failure. So that is associated with lithium exposure in utero. And I guess that's it.